in terms of pre-op, there's the three stages of going through the hospital as a surgical patient. There's pre-op, there's intra-op, and post-op. PAs are involved in different aspects of that. Sometimes PAs are just in the pre-op, some PAs only work in the OR, and some only work post-op, or some do all three. I'm one of the people that does all three. I don't go in the OR that often. I go in on Wednesdays, but we'll talk about that in a bit. That mean? No. Okay. So elective versus emergent. You have to figure out if that patient is coming in electively or if this is an emergency procedure, because that is going to determine whether or not you're going to do certain things, i.e. give certain medications, okay? Whether the patient is in the hospital versus the ambulatory surgery center, that matters. Why does that matter? It matters because of insurance, because even though you may or may not like it, that the way that you bill and the way that you write your notes, they have to look a certain way for insurance companies. In the hospital, or say in the ambulatory surgery center, they may not allow certain patients of a certain BMI. So if you book a patient for an ambulatory surgery center, but their BMI is too high and you didn't check that, your attending physician is going to come back and say, hey, you missed this. There's so many different things on the checklist that you have to describe in order to get through that. Also, ambulatory surgery center, depending where you are in the country, they may do big cases there. They may, and when I say big case, they may do your knee replacement there. They may do your hip replacement there. In an ambulatory surgery center, they may do mommy makeover, or they may do a mastectomy. It just depends on the way that that hospital system is set up. Inpatient, outpatient observation. Why does this matter? It matters because of billing. You'll see when you're practicing is you want to get the least amount of messages per day because your brain can only process so much information. Inpatient is going to be your patient that's going to spend 2 or more midnights in the hospital. So this is key if your patient comes in the hospital and is admitted at 11 p.m. We encourage our residents and our overnight staff to not put in that order until 12:01, just because it gives that patient a little bit of extra time. So if you think that that patient's going to be there several days, you need to put in an inpatient order. If you think that the patient's just going to be there for observation, so say this is an appendicitis, you're admitting them at 2 o'clock in the morning, they get their surgery at noon, they wake up from surgery, they eat a little something, they walk around, they pee, and they go home at 7 p.m. That would be an observation stay. Outpatient, if that patient is deemed by their insurance that this is an outpatient procedure, say they're having a lipoma removal, or say they're having some sort of podiatry procedure, but then they have a weird heart rhythm during the procedure and they need to stay, or they aspirate. We had a patient that aspirated, they were intubated, they were having a hemorrhoidectomy. Very easy procedure, but that procedure you have to be intubated for. The patient was intubated, they aspirated after they were extubated, and they had to be admitted. So the status of outpatient had to be changed to observation. But this is key because otherwise you will get messages from case management and from some person that's probably working in their house. And that's going to take up your day. Do they have a caregiver? Do they have a ride home? Do they have someone to help you at home? This matters in so many instances. This is something that if you work in the outpatient clinic, you need to be asking these questions. If you are in the ER, you need to be asking these questions. If you are working for the surgical team, you need to be asking these questions. Why? If you have a patient that has a colon cancer and has a new ostomy, that's a lot of care. If you have a patient that has acute diverticulitis and they perforate, and now they have emergently have an ostomy, and this person was, you know, previously working and, you know, functional in the world, but then was in the ICU and now has an ostomy, they're gonna need someone at home. They can't necessarily be at home by themselves. Do they have a ride home? These outpatient procedures, I can't tell you how many people say, well, can I just Uber home? Some places allow that. Most places don't, but some places trick people and they say, oh yeah, my ride's here. But some places have the requirement where you have to physically have your ride meet you in the PACU and take you home. So sometimes you have to hire a medical transport service in order to get that patient home. Sometimes as the PA, that is your job in order to get that facilitated through case management. Medications. Did this patient already get their prescriptions? I have a surgeon that is very independent. The one I operated with yesterday, he does all of his prescriptions pre-op. He sends them the day before. And they can pick them up beforehand. I have other surgeons who, that is my role. I have to do all the prescriptions. So we have to figure out, you want to ask them before they have their surgery what their pharmacy is, because after surgery, they're groggy and they don't remember. So you need to make sure that you know that aspect of their care. Did the patient stop the medications as instructed? This is very key because this happens all the time. So say, you know, medications, Xarelto, they go by the generic name, Rivaroxaban. Well, they only know one name, and so they saw the word stop your Xarelto, but they don't know that name for that medication, so they never stopped their blood thinner. And so you have to ask that sometimes multiple different ways in order to make sure that the patients are actually cleared to have surgery. There's plenty of times that they show up in pre-op and the case gets canceled because they didn't stop their aspirin, they didn't stop their blood thinner. They are taking NSAIDs for migraines and they were supposed to stop that, they didn't stop that. Does the patient have appropriate follow-up care in place? So, do they have a post-op appointment? In many cases, the institution will require the patient to have a post-op appointment in order for continuity of care. This is to help avoid patients falling through the cracks and then ending up being a readmission. Do they have PTOT? Is it outpatient PTOT? Is it home PTOT? Do they need to go to a rehab? Do they have wound care set up? Are they going to go to the wound care center physically for their wound care? Or are they going to have a wound care nurse come to the house? These are all things that, depending on the surgery, have to be decided pre-op. Okay, pre-op history. You need to, so this, a lot of these slides for these first two slide decks, this you should go back and reference like the night before you go to your surgery or the weekend before. Allergies, you need to get that history. It's not just medications. It's, are they allergic to certain tape? Are they allergic to latex? Do they have a nickel allergy? Okay, so if they have, say, nickel allergy, if they're getting a certain knee replacement, do they need to order a different product? Things like that. Medications. The most important thing, and it's not on this particular slide, so anticoagulation, chronic prednisone use. What kind of patients have chronic prednisone use? Who? Lupus patients, what else? Cancer patients, not so much, but sometimes. What? Yeah, rheumatoid arthritis. I'm looking for one big group. Addison disease, okay. I'm looking for an abdominal category. IBD. IBD, okay. Your IBD patients. You gotta ask. When were you on steroids? Oh, I'm not on steroids. Okay. Well, did you just finish your steroid taper like 3 days ago and you were on steroids for 8 weeks? Oh yeah, I was. Okay, things like that. And then for the third thing, this is what I want you to write down. Any insulin, okay? How much insulin do they take? When do they take it? Is this someone that just does long acting? Is this someone that does prandial? Is this someone that, does whatever they want? So this is very key. Anesthesia history. Do they have history of urinary retention? Do they have history of post-op nausea, vomiting? Do they have history of aspiration? Do they have history of post-op delirium? Do they have some sort of spinal injury where they can't have spinal anesthesia? So this is not so much you, this is going to be anesthesia getting this history, but things like post-op nausea, vomiting, and things like urinary retention, that is a you question. Past medical history, do they have a history of DVT and PE? Always, 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 always ask this. This is where your lawsuits come from. I've had patients that they have history of DVT, PE, they're like 80 years old, they don't really know that they know the word blood clot. So you say DVT, PE, that's register with them. They don't wear their squeezy boots post-op, they refuse their heparin because they don't want a shot, and they have a DVT. And then the daughter or son come in and they're really pissed at you because they say, well, didn't you know? Didn't you ask mom? You didn't use the word blood. So make sure that not only do you ask the patient, but you go back through their surgical history. It's very easy now because you have an EMR. Remember, I'm old. When I was in PA school and I started practicing it, paper charts. Autoimmune diseases. You want to know this because this links into with steroid use, but also can have autoimmune reactions post-op. Social history, key. How much do you drink? You drink 2 beers a day? You drink 2 12-ounce beers? You drink 2 40s? You know, if these patients, this is another funny story. I had a friend who I actually ended up taking care of her grandmother. Grandma apparently got deliveries from Costco of wine. Grandma drank a bottle of wine a day. So grandma came in with diverticulitis, had surgery, and grandma went into withdrawal. And, you know, no one really put 2 and 2 together. So make sure you ask exactly how much your patient is drinking and put them on CWAP protocol if they're a daily drinker, no matter what age. Smoking history, this is key. You want to make sure that if the patient's actively smoking, that if they need a nicotine patch, ideally you don't give nicotine post-op. We'll talk about that later, but giving a patient nicotine post-op can help, can potentially change the blood supply and hurt wound healing. But if your choices are the patient's going to smoke as soon as you discharge them, or the patient is not going to smoke, sometimes you have to bite that bullet and give them a nicotine patch. Living arrangements. Do they have housing? Do they have somewhere that they can go? And then again, household members we talked about. Okay, so modifiable risk factors. Smoking. So this is all pre-op things that you would be doing, asking in the clinic for the most part. Also some things you would do in the hospital, but smoking. Can your patients stop smoking? You want to think about this, write this down in your hernia patients, in your ortho patients specifically, because you're going to be putting in artificial things into their body. You're going to put, you know, knee replacement, hip replacement. Those are going to be artificial parts putting into the patient, but also with hernia patients, you're putting in mesh. So you have increased risk of wound healing with those patients. If you have smokers, they have an increased risk of those wound infections and for everything to fall apart. So some also with plastic surgery, especially with any kind of rhinoplasty or anything on digits and toes, or the ear. So some surgeons will require weekly nicotine testing and will require their patient to stop smoking. Vaping, please ask about vaping. I can't tell you how many issues I've had with patients vaping. I had a patient vaping in the room on Monday. I'd go take their vape away. Like it's a real issue and it's a real addiction, but it also affects wound healing. And of course, that was a hernia patient with new mesh and they're vaping. So And their wound was already coming apart. So, alcohol consumption, we talked about, if this is an alcoholic, do they need to go to rehab? If this is someone that's drinking too much alcohol, do they need to see behavioral health in order to help decrease? Nutritional status, I'm gonna harp about this in the next 2 weeks. What are the 2 labs that you're gonna look at for nutritional status? Albumin, great. What's the other one? Free albumin. Look how smart you guys are. You know this stuff. Write that down, albumin and free albumin. So if this is a cancer patient, if this is a perfect example, I have a patient who's in the hospital right now. She's been there for 73 days. She's going my client. She had an esophageal perforation, unfortunately, after EGD dilation for esophageal stricture. This was last fall. She failed conservative management. She ended up having to get an esophagectomy in January. Her nutritional status was abysmal because she couldn't eat. So she came in poorly. So these are the patients that you want to look at. Does this patient need a pre-op feeding tube? Does this patient need pre-op TPN? Write this down, feeding tube, TPN. Do they need to see nutrition? Do they need to see the dietitian? And they're a cancer patient and they need to be on certain protein supplementation. Mental disorders. Is this patient depressed, anxious, schizophrenic, bipolar? Does their mental issue impede their ability to follow instructions to take medications as prescribed? If it does, they may need to see behavioral health or work with their psychiatrist in order to help assuage their anxiety or help them get on a consistent medication so that they can be successful post-op. Anemia. Do they need a blood transfusion before they have surgery? Do they need IV iron? Do they need what medication helps with anemia? An injection. Say louder. Epogen. Epogen. Do they need an EPO shot? Those 3 things: iron, blood, EPO shot. Obesity. Do they need to be referred to the bariatric clinic? Do they need to you just need to say, we need to try to lose weight? What do they need in order to be successful? If they're morbidly obese, but they need to have a large hernia surgery, do you need to put that off? Elective procedure. Do they need a knee replacement, but their BMI is 48? They're not going to be successful. So what can you do as a PA to help them lose weight preoperatively? Diabetic status. Do they need to see the endocrinologist? Are they on, what's their hemoglobin A1C? What is their insulin regimen? What is their oral regimen? Do they need Mounjaro, Wegovy, or Ozempic, but you can't get it because everybody's using it for weight loss? All these questions, I know I'm talking really fast, and I know I'm rattling off a lot of things, but I actually go through all this, like, in my head, but I've been doing this for years. But this is what you have to get used to, and you need to print these out in your notes and think about these things. Infection. Has their infection cleared? Have they seen infectious disease? Do they have a chronic abscess? If you're putting in artificial hardware or mesh or something, you do not want to do that while they're infected. Is this a transplant patient and they're chronically infected and you kind of don't have a choice? Are they a transplant candidate, but they have some sort of infection? Is this a patient that's going to be having a valve replacement, but they have a UTI? You need to address all of their infectious potential etiologies before you take them back. And if they say to you, well, you know what, I kind of had a fever yesterday. It was like 102, but I didn't really take my temperature, but I felt like it was 102. I've had surgeons canceled because of that, because they said, you know what, I'm not doing this. We're gonna get a chest X-ray, we're gonna get a UA, we're gonna figure this out, because I'm not gonna operate on you and you have some sort of infection. But it's most important, and this is what I want you to star, is if they see infectious disease and they have any kind of line, they have a midline, PICC line, Metaport, that all of that is cleared and removed before an elective procedure. And then medications, we've already talked about that. Are they optimized? You know, is their blood pressure what it should be? Is their blood sugar what it should be? And are they compliant? Non-modifiable risk factors. This is things that you kind of know about, but still things that you need to be aware of. Age and gender, depending on the type of surgery, genetics, renal patients. We want to think about that. Why? Why do we want to have special consideration of our renal patients?
Increased metabolic rate.
So our renal patients, may need their medications renally dosed and or their anesthesia might not be cleared. So we need to think about that in the pre-op and that what kind of medications are we going to use and how are we going to dose them post-op? COPD. Have they seen their pulmonologist? Do they need pulmonology clearance? What is their oxygen status? What's their smoking status? History of CVA or MI, do they need cardiology clearance? What, if their history of CVA, what is their baseline neurological status? What is their deficits? That needs to be documented pre-op because God forbid it's not, and there's an issue post-op. We don't know. Is that caused because something happened during the surgery or is that just how they are? Heart failure patients, do they follow in the heart failure clinic? Do they need to have a note from their heart failure cardiologist clearing them? Sleep apnea, non-modifiable, but do we need a respiratory therapy consult? Did the patient bring their CPAP? Did they forget their CPAP? Is there a family member that can bring their CPAP? Do they even use their CPAP? Are they lying to you? And then autoimmune disorders, again, we've already talked about this, history of steroid use and consider stress dose steroids. Diabetes, we talked about this. So, you know, it just results in poor wound healing and infection, but diabetics that already have a level of CKD or CAD, this can be exacerbated post-op, especially your patients that they never have surgery, they come in, they get their gallbladder out, and then their creatinine is 1.6 the next day. Or they have a post-op MI. Or they have, you know, a massive incision because they have peptic ulcer disease and they have a perforation and they acutely emergently go to the OR, but their hemoglobin A1C happens to be 13.2 and they don't heal their big giant incision that you just gave them. And that causes all sorts of issues that you'll see in my wound lecture. Goal, okay, this is the goal for everybody, but obviously this is unrealistic for many. You want your hemoglobin A1C to be less than 7. We know that that's somewhat unrealistic. In general, you want to try at least for a hemoglobin A1C of less than 8. You want to address any compliance issues, but this is key. Star this, circle this. They need to cut their insulin dosing if they're going to be NPO. I've had cases canceled because of this. So they take their insulin as prescribed. They take 24 units of Lantus twice a day, and they didn't eat or drink anything after midnight. And they show up in pre-op and they're slurring their words. Why? Because their blood sugar is 48. So make sure that they cut their insulin in half. Make sure if the patient is inpatient that you change the order because the nurses aren't always going to check it or they're not going to catch it. I've had that happen. Honestly, I've probably done that myself. But those insulin orders need to be changed if that patient is NPO, especially think about this. Not every surgery is a 7:30 start. There's plenty of cases that they start at 2, 3 in the afternoon. You need to take off the prandial insulin. You need to change the sliding scale insulin. They might be on high dose. You might need to change it to low dose. Or you might need to hold their long-acting insulin altogether. Okay, nutritional status, we talked about this, albumin less than 3.5. What's a bad pre-op albumin? Do you know what their normal range is? So less than 10 is pretty bad. Less than 15 is not ideal. 20 and up is great. Okay. We talked about nutrition consult already. We talked about TPN and tube feeds. What does tube feeds mean? What do I mean when I say that?
Kangaroo pump is like an NG tube or a.
Yeah, so you can have tube feeds. This patient could be in the hospital and you say, you know what, their nutrition's crap. We're gonna do tube feeds for a week and see how they do, see if they gain any weight, see if their albumin goes up. And they might have a tube down into their stomach, also referred to as a core pack. This might be a patient with an esophageal cancer or thyroid cancer, or just a squamous cell carcinoma, head and neck cancer of unknown primary or known primary, and it's causing them difficulty to swallow. They may need a feeding tube pre-op, and they say, okay, we're gonna do a lap G tube. We're gonna give them nutrition through their stomach for 2-3 weeks, and then do surgery. TPN is not ideal, especially, you're gonna have to do PICC line at home, but maybe that patient needs TPN in the hospital. Maybe they need a month of TPN. Maybe this is someone with the EC fistula. Maybe this is someone with a bowel obstruction. And before you want to operate on them because they have peritoneal carcinomatosis, you want them to be on TPN. Yes.
I'm going back to the albumin.
Yes.
So normal is over 20, you have.
So albumin less than 3.5, the albumin number, that's the number that you're gonna have on your LFTs or on your CMP. Less than 3.5 is not ideal. Pre-op albumin, pre-albumin, less than 10 is really sad. 10 to 15 is not ideal. Your goal is to get to a pre-albumin of 20. Yeah, no problem. I go to Target and I go on and then CVS and Walgreens. And I go on the nutrition aisle and I look at all the products. And I do this fairly frequently just to see what they have. The first thing, I drink OWYN. I recommend this to my patients. Mainly for some of my diabetics because they only have 4 grams of added sugar. And it tastes better than some of the others, some of the Ensures or the Boosts. If you have someone who's just chronically ill, they need an Ensure and Boost because it has more of a fat content. If you have someone that you just want high protein, then you want to do like a Muscle Milk or a Vega. Vega is the vegan option, or a Premier Protein. Do you think Premier Protein is Costco? Yeah, that's not me. High protein diet. So I even tell people, put protein powder in the brownies and give them brownies. Use the chocolate protein powder. You want, chicken, all the things, chicken, fish, nuts, beans, eggs, salmon. But if you have a patient that's a BMI less than 20, these are your patients that have trouble swallowing, have achalasia, have dysphagia, are cancer patients, are heart failure patients. You want a high fat content. This is a lot of information, but I can't tell you how often as a surgical PA, I talk about nutrition. Constantly. Very important to self-educate yourself. I'm telling you, go down on the aisle and see what's there. Okay. Smoking, we talked about this. We talked about the nicotine test pre-op. Did you know there was a nicotine test? Blood test? Yeah. Smoking cessation programs. There's so many resources out there. There's resources in different states. There's resources for different hospital systems. And then depending on the clinical history, please cancel the case if the patient is still smoking. If you're doing certain plastic surgery cases, if you're doing certain complex component separation, hernia repairs, with a patient that's history of poor wound healing, cancel the case. Not that it's your choice because you're not the surgeon, but you need to communicate to your surgeon, hey, they're still smoking. Their daughter told me they're still smoking. Obesity. Anesthesia risk, this is a whole, different risk factor. This is mainly because they may have a very difficult airway because of their size. We've talked about wound healing, we've talked about DVT and PE, and we've talked about, infection risk already. Bariatric surgery, weight loss center consults, they're actually on AAPA. I saw there was an article, it's a PA in San Antonio, Texas, I believe. It has her own, that created her own weight loss clinic through her internal medicine practice. This is the wave of the future. There's so many different, bariatric medicine centers and clinics. So if you're looking for a job, I do see that they write new grads. So if this is something that you're interested in or bariatric surgery, it's a great job, as a new grad. Email me or talk to me about it. I take care of bariatric surgery patients currently. Nutrition consults, this is key. Hernia surgery, special concern because of recurrence. On more than one occasion, I have had a patient recur the day of the surgery. Because they're morbidly obese and they get up and they cough. And their tissues are, there's just so much tissue there and they're already a poor wound healer because they're diabetic and everything else and they recur. Evaluate ambulation status. Star this, circle this. This is your job. Does this patient walk? Yes. So say you have an incisional hernia, or say you have an umbilical hernia, right? And you can, when they cough, you can see it cough off, like a fat containing umbilical hernia or even a valve containing. And you do a primary closure and they cough. Like another hernia. It recurs like that. I even had a patient that they took them back to surgery and then it recurred 2 days later. So do that. Ambulation status. This is your job. Star this, circle this. Does the patient walk? Or do they just get from the couch to the kitchen, to the bathroom, to the couch? Can they do stairs? If they have poor ambulation status, do they need some sort of fitness routine? They need some sort of PT rehab in order to get them there. Because if they can't walk after a major surgery, say they need a fempot bypass, or say they have a AAA and they need an EVAR. They could have major surgery, or they have colon cancer and they have a colon resection. They need to be able to ambulate afterward. If they don't, they're at risk for pneumonia, they're at risk for DVT, PE, they're at risk for death. I know I've said this in the fall, but I've had plenty of patients that they did not walk post-op and they did not walk out of the hospital. Okay, pre-op optimization. We talked about cardiac and pulmonary clearance. These things I'm talking about in the pre-op clinic, but I'm also talking about when they hit the door in the hospital. Maybe the surgery is semi-emergent or urgent, but you still need clearance because it's not worth dying on the operating room table. Yes.
Is there any special things for?
There is in general not, but I have had a patient that had a thyroid storm, that actually ended up having cholelithiasis and needed an ERCP and had cholangitis. So there's always a situation for everything. CBC, BMP, LFTs, MAG and FOS. Why am I getting a PTI and an R? Why? Yeah, bleeding risk and, they may have a history of blood clots. I want to know what their INR is. We talked about their diabetes optimized. We talked about their infections treated and cleared. We talked about their anemia being addressed. Okay. A lot of these next slides, these are reference slides. I want you to go back and I want you to utilize these on your surgical rotation, okay? The American College of Surgeons use a NISQIP calculator. I put this in, this is to, determine the risk of complication or death. I had, at my old institution, they would actually write the NISQIP score and they would document this in patients that were high risk. They'd be like, we educated them that there's like a 27% chance of death based on their NISQIP score, and they still wanted to have surgery. If you give your preceptor their NISQIP score, they're gonna think you're really smart. So use it. But this is the link. Caprini score. We use this all the time at my current institution. I didn't use it as much, or even 5-6 years ago at all. Star this, circle this, because Caprini score, who has MD Calc on their phone? I know I told you. Who doesn't have MD Calc on their phone? Oh my God, put MD Calc on your phone before your rotations, because you'll be sad without it. Or just like use it on, you can just Google it. But it has all the different calculations that you'll ever need, and one of them is the Caprini score. So this is the risk for thromboembolism. This is important because if the patient has a high Caprini score, so say you just did laparoscopic Nissen fundoplication. What's Nissen fundoplication? Do you remember?
Hiatal hernia.
Yeah, you for a hiatal hernia repair. You wrap the stomach over around the esophagus. But their Caprini score is really high because they're old and they have a history of a DVT and they have I don't know, obesity and a whole bunch of other things. If their Caprini score is high, they need to go home on anticoagulation. Yes.
What's a high Caprini score?
High Caprini score, so 4 is the top normal, 5 and above, typically. This is just a general chart that I use for different types of insulins, what to give and not give night before the procedure and morning of the procedure. This is a chart about stopping anticoagulation for planned surgery. Honestly, I'm barely seeing any Coumadin. Like that has really dropped off in the setting of Eliquis and Xarelto. I have such a hard time saying Xarelto. Riva Roxaban. Thank God they have the brand name Xarelto. But this is the half-life, and these are general recommendations of when to stop. But remember, always confirm this with your supervising physician. This is just a general. This is just a general slide about different biologics, different medications for rheumatoid arthritis or your lupus patients. Or these can be for your transplant patients and dosing intervals. There's so many different charts, but I provided these for you just so that you can have a gauge and you can use this on your surgery rotation. Okay, the American College of Cardiology, I don't know, these recommendations, honest to God, I feel they change every 6 months. So I put this chart in here, but make sure that you reference the American College of Cardiology for when to stop their hypertensives, but also use the cardiology consult if you cardiology clearance if you don't know. Some patients, for the most part, generally, they gotta continue their beta blockers. But you're definitely going to stop their diuretics. But there are certain patients that you continue their diuretics. For statins, in general, they don't need a statin, but the patient's gonna be like, I want my statin. So you tell them it's safe to not take their Lipitor for a day or 2 or 3. Aspirins, write this down, star this. It really matters if it's 81 milligrams, 162 milligrams, 325 milligrams, and why they're taking the aspirin. Are they taking the baby aspirin because they just had a joint replacement? Are they taking the baby aspirin because they had a heart attack 8 years ago? Or are they taking the aspirin because they just had a stroke and they're on 325 milligrams of aspirin? Much different management plan. True story, happened this week. I had a really uncomfortable, embarrassing conversation with the family. Now, I did not do this. Someone else in the hospital did this, but in the med rec, it said 325 milligrams of aspirin. Nobody asked the patient how much aspirin he takes. He said 81 milligrams. We got cardiology clearance. They wrote in their note, continue aspirin. They didn't ask either. Nobody asked until myself and the chief resident went in the room and he said, oh, I just take the little one. How much is the little one? Oh, I don't know. And the attending teased it out of him that he takes the 81 milligrams. Well, we put this patient that was going to get their gallbladder out, a semi-elective procedure. He had his ERCP last week for his full lithiasis on 325 milligrams of aspirin. His case was very bloody. It was very unfortunate. Luckily, he did not require a blood transfusion, but that patient lost more blood than he needed to. It happens. Mistakes happen, but you have to ask your questions very, very well. And you have to ask them sometimes 2 or 3 different ways. Chad's VAS score, for atrial fibrillation, for stroke risk. This should be documented in your notes, and you should calculate this on your own. If you have a patient with atrial fibrillation and they are going into surgery. 1, you're gonna look smart, but 2, and honestly, we got, okay. So I would say Caprini, your NISQIP, and your Chad's VAS score are the most important. So I want you to make sure that you know those, and have access to those in MD Health. Well, NISQIP is its own, it's on its website, and I put that website link in. Cirrhosis. This is, I would Google this, because this is an evolving score. Honestly, I even talked, like 2 weeks ago when I was doing some of these slides with the transplant hepatologist. And they're really changing the different scoring systems for the mortality and morbidity predictors for cirrhotics. But what do we worry about with cirrhotics going into surgery? I know somebody knows the clotting factors. Okay, so what are we worrying about? Okay, so what if someone's cirrhotic? What is their platelet count? Low. How low is low? I'm just seeing if you know this.
10,000.
Okay, 10,000. Yeah, that's really bad. So do you go to the OR if it's 10,000? No.
No.
What is the cutoff for most surgeons? I think you said it.
I said 50.
Yeah, it's 50. In general, most surgeons, depending on the surgery, want 50,000 platelets. So they want a platelet transfusion to get them up to 50,000. So even if it's at 48,000, they're still gonna want a platelet transfusion, okay? But if you have a patient that's cirrhotic, you need to do a surgical, risk score, and the vocal pen is like the new score. Did you guys know that there was all these scores? You did. Okay, good. That's good. Malapati score. This is what you're gonna get with anesthesia. So class 1, you can see the soft palate, you can see the entire uvula. Class 2, you can see the entire uvula, but the tongue comes right to the inferior aspect. There's no black dark area, or you can see the back of the palate past the tongue. Class 3, you can only see part of the uvula. Class 4, it's not visualized at all. What type of patient is this? Class 4. Obese? What's the other thing? Sleep apnea. Okay, your sleep apnea and your obese patients are your class 4. some of these patients, if they are, they have a, if they have a class 4 Malaparti score, and depending on the type of surgery, so say they're getting a transplant, they may leave that patient intubated because there's such a hard intubation that if they decompensate an hour or two after the procedure, it's very, very, very bad. Oops. Yes. I don't know, Tiffany. I don't write the exam. Say that, say it louder.
I would ask about the scores and how the procedures I would be aware of some who needs them.
Yeah, so who needs them and what they're for? So like a CHADS VAS score is for atrial fibrillation. So if the choices are like atrial fibrillation, diabetes, sleep apnea, or IBS. You don't need to know the components of the score. I don't know the components of the score. Tiffany doesn't. We all know it. You use MD Calc. But you need to know why, you need to know how to use them, why to use them. All right, this website, I don't know why it's not clickable, but it's not. And that's okay. I want you to go to this website because it's the, I don't know what it actually stands for, but it's the American Society of Anesthesia, something. It is such a good example of anesthesia 101. And like, I know we say, go home and read about this, but like, I really want you to click on this website and I really want you to go and read about this, before next class. It's talking about the differences in the types of anesthesia and why you would use it. I, as you can tell, love to talk and could talk all day, but if I went into each one of these different categories in depth, we would literally be here until you graduate. So some of this you have to do self-learning. This is one of those things I decided you have to do self-learning on. But you can scroll through this link in about 10 minutes. It'll take you. So general anesthesia is used for most major operations. You completely lose consciousness. So this is, but believe it or not, star this, circle this. All of your buck cases, in general, are going to use general anesthesia because those patients have to be intubated because you have to prone them. So even though it's a really easy case and it literally takes the surgeon 8 minutes to do, the anesthesia time before and after is 45-50 minutes because you have to intubate the patient, get them asleep. You have to flip them from the stretcher to the table, adjust the table so that buttocks is in the air, do the surgery, then you have to decrease the sedation, wake them up, and then flip them back over onto the stretcher and then extubate. Takes a long time. IV monitored sedation. Honestly, they do a lot of plastic surgery with IV sedation. One of my closest friends, she's a plastic surgeon on the Upper East Side of New York. They have their own surgery center. They do their tummy tucks, they do their breast implants, everything is IV sedation. Rarely do they do anything with general anesthesia at all. If they do, it's in the hospital. But IV sedation can be used for colonoscopies. IV sedation is used for hernia repairs. If Dad had his hernia repair with IV sedation. I don't know if you remember that you had a hernia repair. Yeah. Yes. General anesthesia, so that's where I want you to look and click through these. It's the type of medication used. So they are using medications so that you are completely out and that you've lost consciousness. IV sedation, that is like your propofol. Okay. And then other things that are used for monitored sedation, the like melanoma, A lot of melanoma cases are IV sedation, a lot of podiatry cases are IV sedation. Smaller cases, they can do without general anesthesia. And usually they will protect the airway with an LMA rather than intubation, okay? Or depending on the surgery, it'll just be non-rebreather mask. Regional anesthesia, that's used for childbirth, so like with your C-sections. Also regional anesthesia is used for many, they're using it for breast surgeries now, for mastectomies. They're using it for surgeries of the arm and leg. It will numb the entire extremity, but you will be awake. Same thing if you're having a C-section, you're awake, you're not out, but you are numb. And then local anesthesia, this is just injecting into a very small area. You can do this for certain anorectal cases, but also to have moles removed, melanomas, small lipoma cases. Any other questions? So like your general anesthesia, that's using your rock, your succinylcholine, it's your full medications. The patient's completely out. An on-cue pump. So on-cue pumps are has anyone ever seen these that worked in the hospital or had surgery or? Okay, so this is an on-cue pump and you can Google this, but they're little bulbs and they go home with the patient in a purse. And all of our breast patients use these and it provides the patient continuous numbing medication. It may be bupivacaine or it may be a lidocaine derivative. And it's used in order to continue to give anesthesia in that area, in that dermatome, and try to minimize narcotic use. These patients will go home with this and they'll pull it out usually around post-op day 5. Patients cannot shower with this in though. So that's a key point. Also, star this, circle this. So everybody has generic post-op instructions, like generic mastectomy, generic knee replacement, generic gallbladder, whatever. And it says like, oh yeah, you can shower. But then they go home with something like an on-cue pump and they say they can't shower. And they say, well, my doctor's note said that I could shower, so I showered. So you want to make sure that you edit all of your post-op instructions so that everything is in congruence. I had a patient yesterday who had surgery because she had BRCA2 and had breast cancer at 36. And she had plastic surgery involved, gyn-onc involved because she ended up having an oophorectomy as well, and she had a mastectomy. You had 3 surgical teams seeing her, and you had 3 sets of post-op instructions, all that said the same thing, but said a different thing at the same time. Some things use the word 24 hours, some things use the word 72 hours. Some said you could eat at this time and this type of food, some said something else. So you have to edit those so that everything is in congruence. And you have to talk to all, as the PA, I had to talk to all 3 services and make sure that everyone was in agreement with what the actual discharge plan was and not just click on the button, oh, we're putting in these 3 instructions and bye, go read them. This is, I know this is maybe sounding overwhelming to you, and as a new PA it was, and I stayed late and I had to read a lot of stuff, but this is your patient. You have to take ownership for this. You gotta, everything that you give to them, you gotta read yourself and make sure that it makes sense. Okay. This is just I put in a slide for the different positioning. So when I say prone, this is prone. It's hard. I was in a case a couple weeks ago where the strap for the arm wasn't really strapped in that great, and their arm like fell off as we were moving them back to the structure. But they're asleep, remember, they're asleep and they're intubated, so their arm just up. So when patients say things like, oh yeah, my arm hurts after, or my leg hurts, well, that's because your job is to protect them during the operating room. And your job is to operate as well. And the scrub and the circulator is it's also their job to protect the patient, but it's everyone's job to protect the positioning. This is Fowler's position. It's used for certain neurosurgery and shoulder surgery. Lateral position, this is for your thoracic surgery. Why is that? Why do you think?
Separate the ribs more.
Yeah, so you're going in through the rib cage, and so you're going in through the side. For lung surgery. Certain neurosurgery, so your spine surgeries may be in this position, depending on an ENT position, if you're doing things for head and neck or ear. Lateral position. Supine position, that's position for most cases. Lithotomy, this is your colorectal, they don't use it that much, they use it more for prone, but for your rectal prolapse patients, use this position. Gynecology uses this, and then urology. So for all your kidney stone patients, they're in the lithotomy position. But also any kind of bladder, or ureteral, intervention. It's not comfortable either. It's okay, take a break. It's not being more comfortable.